Hello friends, welcome to our channel. We are going to be talking about basics of implant dentistry. Before I get to it, I'm going to invite my colleague, Dr. Vishal, who's a practicing periodontist from Houston, to join us in this session. Hey, Dr. Vishal, how's your day today?
Good, how are you?
My day is very well. So I'm going to get started with my presentation right away. The topic for my presentation today is single implant planning, first restorative considerations. It is what I call FRC. This is a protocol that I follow in my practice, and this is just some sort of a guideline so that we don't forget or miss out on anything. So what are the guidelines? What is FRC? The first is patient history and expectations. Second is existing dentition and radiographs. Third is the nature of the defect. Fourth is the smile line and buccal corridor, and fifth is the occlusal considerations. When it comes to the first point, that is patient history and expectations, it is very important to know what the patient wants, or else we may end up in some unwanted situations like these. It is very important for us to identify what are the problems the patients have and what are their expectations. Along with this, it is also important that we need to educate our patients so that we can manage their expectations. And of course, medical history becomes a very important part of this so that we don't end up in situations where we are midway through a procedure and realize we shouldn't have done something in that particular manner, and we may not get an ideal outcome that we had envisioned. So after talking to the patient and establishing some initial contact, the next step is to look at the patient's existing dentition and radiographs. It is important for us to know what teeth are missing, where are they missing, either anterior or posterior, or the patient's missing more than one tooth or teeth. And of course, we need to know whether the patient has some restorative work done in the past, whether it's single crowns, root canals, some fillings, or if the patient has had extensive full mouth rehabilitation done. We also need to make sure if our patient has failing dentition that needs more comprehensive and extensive care, such as generalized periodontitis, infection, mobility, as you can see in this above picture. We need to keep these in mind from the get-go and have a more global overall vision and not tunnel vision when we are doing our examination and treatment planning. The next step in FRC, or first restorative considerations, is evaluating the radiographs, which have been discussed in our previous videos as well. For me, when a patient comes to the practice seeking care, one of the first things we do is take some periapical radiographs, maybe a full mouth series and a panoramic image. If we know that this patient definitely wants to get an implant, and if we know he's referred from another office, then we definitely take a CBCD right away. But if not, we take one after talking and discussing some preliminary treatment options with the patient before we provide the patient with the final treatment plan. Next, we are looking at the localized site and the nature of the defect at the missing tooth site. Now, this could either be a soft tissue defect or a combined soft and hard tissue bony defect. It can also be an asymmetrical defect between two contralateral teeth, for example, number 7 and 10, the lateral incisors here in this picture. The treatment plan needs to be adapted and altered for what needs to be done for each site in a situation like this, and there is no cookie cutter recipe here. Apart from the asymmetry and tissue involvement, there are volumetric defects that can involve just the height or the width of the bone, or it could be a composite type of defect involving both the height and the width. And these things are significant, and we need to inform the patient on the consequences if they do not follow our treatment plan. And obviously, patients want their tooth at the end of the day, and if you have not detected these defects earlier, then it becomes more of an excuse at a later date. I will illustrate the significance with one of my own patients. Now, this patient has a good smile line with acceptable aesthetics, but if you see closely intraorally, you can see the huge combined and composite 3D defect, including the height and the width of the bone and soft and hard tissue as well. This patient was given multiple treatment options at the time of planning and eventually was decided upon to do implants and not a lot of extensive bone grafting, but replace it with prosthetics. Not every patient will accept this, and therefore we need proper diagnosis and treatment planning at the start. The next principal consideration is aesthetics, the smile line and the buccal corridor. Now, we have heard about low, medium and high smile lines, but what we are looking at from a restorative perspective. So I'm going to share a quick hack of how I evaluate my patient's smile line. I have the patient give me their regular smile, but I also ask them to force an exaggerated E smile because in everyday life, ecstatic, humorous situations and big celebrations often involve wider smiles and laughter. Now, as seen in this patient of mine, a low to medium smile line looks more of a medium to high smile line when exaggerated. Now, in patients with high smile line, the gingival display becomes even more prominent. Thus, it is imperative to note this down, both regular and exaggerated smiles. So this could also determine the level of complexity and the number of treatment procedures that you need to offer or provide for the patient, especially when considering restorative replacements for missing teeth. This is not the only way, but a quick system I follow in my practice. Additionally, there are some other variations that I've identified, 3 more to be precise in my everyday practice. The very high smile line, where the exaggerated and the normal smile lines are the exact same. The very low smile line, where we barely see any teeth even at full exaggeration, and the one where the patient does not want to. Maybe because they are ashamed or embarrassed and don't really smile in public with any kind of tooth display. Sometimes I have to coax them to force even a slight smile out of them. The next aspect in FRC is the buccal corridor that indicates the smile width. It is the negative space, the dark space visible during smile formation between the commissures of the mouth and the buccal surface of the maxillary teeth. Now this is the average or medium buccal corridor space, but then you will have patients with narrow buccal corridor space or even asymmetrical space between the right and the left sides, and then you will have patients with wide buccal corridors or narrow smile width. Lastly, we must account for and assess the patient's existing occlusion as a part of FRC. This is again a sort of a checklist I follow, and dentists can follow another pattern if they so prefer. First thing I check for is the presence of any diastema and to see if the other teeth show spacing or not. Next, I look for the presence of crowding in the arch that you are planning to restore or the opposing dentition. Then comes the angulation of the teeth in 3 dimensions, and I need to make sure if the patients have or have not gone through any kind of orthodontic treatment. In addition, as a part of FRC, I want to assess attrition with the existing teeth and if we have limited interarch occlusal or restorative space for the restoration. Then I check if the patient has a deep bite and limited space as a result of that. And lastly, if the patient has a reverse bite and a lack of restorative space, and what are the solutions that we can offer for this patient considering the limited space that we have. These things need to be considered. Lastly, for FRC, few more parameters that I assess when considering occlusion. It is the centric, so that when the patient is in maximum intercuspation or their habitual biting position or MIP, then in excursive movements, both right and left excursive movements, I want to see what kind of guidance does the patient have, canine guidance or group function, how is the anterior guidance. And at the end, I look at the opposing arch and see if there is supra-eruption or over-eruption of teeth with long-standing missing teeth, which will affect your overall treatment plan, and we have to educate the patients on these. So, in conclusion, a patient case selection is very important. You need to look at the overall picture and not just the particular tooth that you are replacing. Then when you are doing treatment planning, you want to go through a sequence of periapical radiographs, panoramic radiographs, full mouth series, and CBCD planning so that we are not missing out on any other details or pathology that could affect the treatment plan. And obviously for the missing tooth, you are looking at the defect in detail in 3 dimensions and seeing what kind of structural loss you have. And then obviously aesthetics and occlusal considerations are very important. Aesthetics include smile line and buccal corridor, and occlusal considerations include more than enough space, less than adequate space, excursive occlusal contacts, guidance, and supra-eruption is all taken into consideration when we are planning for a single implant restoration, and these are my first restorative considerations for a single implant restoration. And that's it for my presentation. It is a very basic topic, and I've only covered sort of a sequence that I like to use in my practice. And if you have any inputs, please feel free to put them in, Dr. Vishal. Over to you.
In implant dentistry, there are so many aspects as you mentioned in your presentation. There's a smile line, there is occlusion, there's a CVCT planning. So it goes a lot when you're considering implant dentistry. So thank you for the presentation.
So before I let other viewers go, I'm very thankful that they have been paying undivided attention to our videos. And if you as viewers have any comments or questions for us, please leave them that in the comment section. And thank you so much, everyone, for watching. And thank you, Dr. Vishal, for an amazing discussion today.
Thank you.